To begin with, one second. Yeah, my name is Sangeeta Agarwal, and I'm a practicing gastroenterologist for 24 years now, and also been practicing yoga for 11 years. My interest in yoga came after I started noticing that a lot of my patients were not actually getting cured of the diseases. Maybe we were able to control or suppress the disease in any way. And the thing is, in medical school, they teach us about the pathophysiology of disease in the form of physiology of how the body functions, which is important to know and which is important even for yogis to know, which we learned during this course, but also the pathology of how, specifically, how a plaque forms in a carotid artery, what are the um, what are the risk factors for having gastroesophageal reflux disease. But all that is very scientific way of explaining it, and not too much stress is given on telling the importance of stress or lifestyle factors in the causing these diseases or in the pathology of disease. So in medical school, we didn't spend so much time. We spend some time learning about how our sympathetic, our autonomic nervous system works in fight and flight and things like that, the common thing. But it doesn't take you to the basics of how it settles in one organ of the body, depending upon the genetic predisposition and the personality of the person, how it can fixate in, say, joints and cause arthritis, or maybe your GI system is more vulnerable and it causes that. What I realized is, even when I was practicing, whenever I was stressed out, I would have low back pain. So that was my vulnerable area. So everybody has a vulnerable area, which may be a muscle or an organ, in which if it is just a short-term stress, it may fixate in a muscle or a joint. But if it is a long-term prolonged stress, it can actually hone into an internal organ and cause problems, like even say diabetes or heart disease or inflammatory bowel disease or IBS and things like that. So it was interesting for me to learn about the concept of panchakosha. Okay. And the panchakosha relates to the five sheets or layers of our body. The outermost is the annamaya kosha, or the physical body. Then comes the pranamaya kosha, or the vital energy body, which the prana flows into each and every cell of our body and provides it the vital energy, which you can explain in terms of medicine as oxygen, nutrients, or things like that. But that's the prana, the vital body. The third is the manomaya kosha, or the emotional body, which is, I think, the root cause of all problems, and I'll come to that. And the fourth is the vijnanmaya kosha, or the intellectual body. And of course, the fifth is the anandmaya kosha, or the blissful body, which we can only hope to achieve. And it's something which is not easily achievable, right? At least for us. So if you can think of, the more subtle the treatment level is, if you reach the Anandamaya Kosha, then you are free of all disease. Then you are in a perfect blissful state. If that's not going to happen, at least if we work on Vijnanmaya Kosha and start to apply intellect by reading self-help books and saying, this is the cause and this is how we need to treat it, maybe we can achieve. It's also sometimes very difficult to think intellectually. Intellectually, I may know that the stress causes this problem, but I may not be able to apply it to myself. So that's where these practices come. So how we practice is, if we are able to, usually stress arises in the manomaya kosha, like the emotional body, then it percolates into the pranamaya kosha, and then it goes and hones into the annamaya kosha, or the physical body, right? If we are able to control at the manomaya kosha by meditation, chanting, and all that, then we can help. That is the root cause. We can help. But again, the problem is, if you stop practicing, everything falls off. So it's not just a thing that you practice and treat. It's a lifestyle. So for me, yoga is a lifestyle. It's not to be practiced for say 3 months and then my problems are solved, right? That's not going to happen. So it's a lifestyle. So basically, we start treatment with physical body annamaya kosha because most patients relate to that. Okay, when you're telling somebody who's a beginner about yoga, they first relate to it as asanas. So, okay, you start teaching them asanas, and then you say, okay, now with asana, you engage your breath with it, you synchronize your breath with it. So, slowly, they're bringing their thought to the breath because they have to synchronize it with the asana, and then they come to live in the present moment. So their mind is not now wondering about, oh, my kids are going to come, I have to cook. But because I'm telling them repeatedly, or we are telling them repeatedly, listen, focus on your breath. Okay. This is when you inhale. This, you take a deep breath, and as you exhale. So unknowingly, they're bringing their focus to the breath. And that's how I feel that their physical ailments get some relief. And that I've practiced myself. And when I started practicing yoga, I noticed I was going through a stressful situation. And instead of taking medication and all that, I joined yoga. And I realized that as long as I practice yoga, all those psychosomatic complaints which I was having were gone. I was not irritable, I was not snappy, and things were going good. So that's when I realized that this is very important as a physician to integrate into the regular conventional medicine. And I'm lucky that I work in a hospital where we have what we call a whole health program or an integrated health program. It's a full-fledged program where we have a physician who's in charge of the whole health. I'm also I'm a specialty member of the program. We have yoga teachers, we have meditation teachers, we have Tai Chi teachers, we have music therapy, we have sound, and I can actually prescribe these to my patients. It's only getting the patient to come to the same page is what is difficult, because they come with a perceived idea of, I'm seeing a specialist and she's going to cure my reflux disease. And when I start talking about other things, it takes a while for them to understand the importance of it. And so that's how I got interested in yoga. And that is now my basic understanding of pathophysiology has widened from just the basic to this overall approach of the 5 sheets, which is very important for us to realize. Any questions you have here, or should I continue with my case? Or
yeah, anyone with any questions? I don't have questions.
A couple of general questions so I can get some context. Where are you located? Where is the clinic?
I'm in Dayton, Ohio, and I work at the VA hospital. So this whole health is now a national thing in VAs across the nation.
Whole health. Okay. So it's a program that's being introduced in many clinics now?
Oh, it's been here for at least 10 years. And in VA, but it's gaining popularity in the last 4 or 5 years, especially after COVID, because more physicians are rooting for it. Like if you ask in my hospital, I'm sure 60% of the physicians don't know that it exists. Okay. So, so I do grand rounds and things like that, and I bring the whole health team together, because in grand rounds we expose ourselves to the whole hospital to bring it to their attention, and they say, "Oh, we didn't know it's there." So they don't do a very good job of publicizing it, but it's there. And I think it's a great thing they're offering to veterans, because if you, like outside, you cannot prescribe yoga because it's not standardized, right? And it is expensive, and insurance will not pay for it. So if I tell anybody in private practice to do yoga, I'm like, I don't have money to. And then it has to be also focused to disease specific a little bit. You can't just, I mean, if you're otherwise healthy, like I was when I joined, it's good. Just join and then you will realize what works for you and what doesn't. But if you are suffering from a specific disease, then I don't think just going to some yoga studio and doing yoga will work for them. And it turns out to be expensive and
as a fact, it could hurt them also, right?
exactly. So it's, unless it becomes a standardized practice that we have yoga therapists to whom we can refer them in private practice, and then insurance pays for it. It's not going to come into the routine thing. That's what I feel.
Very nice.
So as a gastroenterologist, like GI tract is called the second brain, right? So there is what we call the gut-brain axis, and we are taught about the gut-brain axis. So that part, at least, how the gut and brain interact with each other. And the simple example I give my patients, which everybody can relate to, is people say, "Oh, I have butterflies in my stomach when I have to go for an interview." Why? Because you're feeling nervous, right? Some people have diarrhea right before exams. So all those are stress reactions. And if it is prolonged for a long time, then it can cause chronic problems. So it depends upon the amount of stress and the resilience of the person. So then the three patients whom I have a whole group of patients in the study, but for the thesis, I just took three patients. And the reason, and we administered them the perceived stress scale, because the perceived stress scale is which is the standardized stress scale. And we measured it before and 3 months later. And then we also had a disease specific scale. For GERD, I had a reflex disease questionnaire. And for irritable bowel syndrome, I had the IBS severity score questionnaire. And for inflammatory bowel disease, I had the Mayo disease score questionnaire. So we had a disease severity score and a perceived stress score. And we offered them the yoga therapy in addition to whatever conventional medicine they were taking. So gradually, and since this was only a 3-month trial, and now it has been more like 8-9 months, and these are still my patients, slowly I'm weaning them off some of their medications. So that will be the paper we'll publish after the whole research thing is done. But that is the goal, to minimize the number of medications they're taking. So I start by telling the patient to see, do you like the number of medications you're taking? They say, no, it looks like I'm taking a bunch for breakfast and I don't even feel like having breakfast then because my stomach is full of medicine. But okay, so let us work together in getting rid of some of them over a period of time. So in this patient, the first patient which I had was actually a post-menopausal lady. And this lady was really very anxious, irritable. We call it like this type D personality, like a distressed personality. Like for everything, she had a negative emotion. And this patient had heartburn for several years. She was taking the medication, the protonics also, for a long time, but she was not, she was also gaining weight instead of losing weight, which is actually making her GERD worse. And she didn't eat anything during the day. She had a very irregular eating pattern. And then during the night, because she couldn't fall asleep, she was eating in the night and she was having symptoms. So she had a very bizarre eating pattern and her lifestyle. And also she was constipated. So a lot of things were happening. She was 57-year-old, so she was post-menopausal. So a lot of hormonal changes happened at that time. Her kids had left for college. She was a little depressed and anxious. And she was just focused on her GI symptoms. But when I took the time to talk to her about this, and I've noticed that some of the patients, if you take the time to talk to them, they will talk to you for a long time. It's just that a lot of physicians don't have the time to talk to them. Like, okay, GERD is not controlled on protonics, I'm going to increase it to twice a day. End of story, and go home. But especially for GERD, for a long time, I have been practicing diaphragmatic, not only for this patient, but I've been showing them how to do diaphragmatic breathing. Just to explain also that diaphragm is also muscle in your body. When you strengthen the diaphragm, this is an exercise for the muscle, which is diaphragm, just like we do exercise for the other muscles. And then there is actually a video from University of Michigan website, which explains diaphragmatic breathing. And a lot of research has been done on the effect of diaphragmatic breathing on GERD. So I have some evidence base to support this thing, and I explained to them. So for her, we worked on first the Annamaya Kosha was her diet and her lifestyle. So she's obese. She was not eating properly. So that was the first thing we wanted to work on. So I explained to her, even if you're not hungry, start eating small, frequent meals at regular intervals, just very plain, simple meals, no caffeinated or carbonated drinks. And then to stop eating 3 hours before laying down. Okay, so we had to work with her very slowly, because if you give them too many things to work on at the same time, then nothing gets done. So I usually start with something very simple, which is in their control. And instead of seeing them back in clinic, I do a telephone visit after the initial thing to say, hey, listen, did you work on this part? I said, yeah. Then they'll have some complaint, like, it's okay, just stick with this part first. And then we will start with walking, like to reduce. So in order to tell them to reduce their weight, we have to say that, because the belly will press on your diaphragm, it makes your hernia worse and your acid reflux worse. We just need to get this going. So she started walking with her neighbors. So that increased her social life also, that she was now chatting with her neighbor and also walking. So that really helped her. Even if she did lose some weight, but even if she didn't lose dramatically, just the fact that she was walking with the neighbor and eating at regular intervals showed that there was some improvement. And then she got into this yoga therapy. And then I took her to the yoga therapist. I introduced her. And so the yoga therapist, I gave her the instructions on what I wanted to be done for this patient. And she said, okay, because ultimately I can't go and teach her yoga, but I can give my yoga therapist. In this study, we have given the yoga therapist some instructions on for GERD patient, this is what we are doing. For IBS-C patient, IBS-D patient, and IBD patients, this is what they're doing. And depending upon what patient is interested in or likes, because they're not going to, then we will hone down on that one simple thing. So this patient, she liked the arm movement in breath and body synchronization. She liked Marjalasana and Shashankasana. They're pretty easy. I've seen that with most of my patients. Those 3 things are always the winner. And then Pavan Mukta Kriya, it is sometimes they find it embarrassing, but once they see the effect of how, because that is really effective. That is very effective in releasing all this bloating and flatulence and everything. Then diaphragmatic breathing, I always stress on, and she did diaphragmatic breathing. Then this alternate nostril breathing is another thing. So she started doing this. So at asanas and some of the breathing, we got it. And then to get into chanting, the only thing which we tell our patients is Om. Or if you don't want to do Om, if you have this thing, Nowadays, I don't find any resistance in Om chanting because you explain to them separately the influence of A, U, and Ma without, there's no religious connotation to it. It's just the three sounds. And they're fine with that. And otherwise, I just tell them to close their eyes and just do so that they feel the resonance. And she actually was fine with it. Then she also started volunteering at the church. So slowly, because she started getting out of the house, she didn't feel lonely or depressed and accepted that this was a new phase of her life. And her GERD symptoms, I still see her. And initial EGD, if you see, she had severe grade C ulcerative esophagitis. We do repeat the EGD after 8 weeks to confirm healing. And initially, I had to double up her protonics to twice a day, repeat it. It completely healed, then took it down to once a day. And now she's on just half the dose as needed. Because she's now she's really motivated. This is one of my rare patients who is really motivated now to get off her medications. So I'm happy to see her progress, even though I still tell her to take just a small dose of 20 milligrams half an hour before breakfast, so that her ulcerative esophagitis doesn't come back again, because that's a known risk factor for cancer. But that was one of my patients.
Just amazing. Beautiful. Any
Yeah,
questions?
this is,
Anyone?
yeah, I read the Sangeeta ji's dissertation, and it was just, I said, who is writing this paper? I mean, I'm just, I couldn't believe, and this has been the best ever so far, right? I mean, the entire, it's just like a dream come true, like, whatever.
Hey, I mean, I'm really passionate about it. At the American College of Gastroenterology, last year in Vancouver, I did a yoga session, which a lot of people attended. This year again in Philadelphia, I'm doing it at 6 a.m. on Sunday, along with another guest. So at least I've seen in gastroenterologist field, they have begun to accept that, especially for functional disorders like irritable bowel syndrome, dyspepsia, bloating, all they come under Rome Foundation of Functional Gastrointestinal Disorders. And instead of, previously people used to tell them, oh, it's all in your head, which no patient is going to like it if you say, oh, it's all in. They are having symptoms. You can't just say it's all. Yes, it's in your head, but it's affecting your gut because of the. So I have also done some research on gut microbiome with the molecular biology department in Wright State University on the effect of gut microbiota in IBS, but not that didn't involve the yoga part. I got into yoga afterwards.
What is
So how
the?
many people did? Yeah, sorry, Mona.
Oh, go ahead.
Now, I was just going to ask, what was the number of you have given 3 case studies, right? You
Yes.
said you had many more than those.
Right. So we have now we have a lot of patients who are in that yoga clinic. So IBSC, IBST, some of the IBD patient as adjunctive therapy. So we will collect the yoga therapist is collecting. So I have given her the perceived stress scale and the disease severity scale. That is collected by a nurse every time they come. She goes over them and collects that questionnaire. Then the yoga therapist works with them in group. Now they have group lessons, because initial 1 or 2 lessons they have individual, then they go into groups. And they also have tele yoga. So some of them can do it from home. If they can't travel that much, she does it through. So once, yeah, I have to get back with her to collect the data, but it's going on slowly. It's staggered, like different patients are coming at different times and enrolling.
Very nice. Mona?
What is the prevalence of these different subtypes? So, what percentage would you say come in for C versus D?
Oh, okay. So IBS C is constipation predominant. IBS D is diarrhea predominant. And IBS M is mixed type. Sometimes they have diarrhea, sometimes they have constipation. And IBS U is unclassified. So in majority of younger women, I see IBS D. That's just maybe, and then in majority of older males, IBS C is more predominant for some reason.
Mhm.
So I don't know, in younger people, we see more diarrhea predominant or mixed type. And in a little middle-aged and older, we see a little more constipation predominant or unclassified. Unclassified meaning you can't, sometimes their main problem may be pain relieved by constipation, a lot of bloating and dyspepsia. They meet the criteria of IBS by the Rome 4 Foundation, but they don't come under any of the three types.
Mhm.
Yeah. Any more questions, Mona? Can I ask?
One more question is when you first do the intake, you do the kind of a yoga therapy focused intake, I'm guessing, in explanations. Do you introduce Panchakosha to them? You give them
I
that?
do draw. I like to draw and show, even when I explain to them the pictures of GERD. I draw and show them the same way I do draw this picture, just for them to understand a little bit, not necessarily using kosha, but just physical, mental, intellectual level. Briefly, there are some patients who will show interest in knowing more. Some of them will just listen. I don't know how much they understand, but the therapist at least knows that, we have to get the prana into the focus and focus on breathing. And also they build a social circle there, right? Which also helps a little.
So how many generally in one group, how many do you find come to the group lessons?
So I have, sometimes she just has 4 or 5 in one session, but they're never more than 10.
Never
I
mind.
mean, I've seen maximum 7, 8. Because I
have a
don't
question.
know whether because as I said, half of our hospital doesn't know that we have this facility. So there are also some people who like Tai Chi,
Mhm.
and so there's another therapist for that.
Nice. I have a question regarding the case, I think it's case 3, the IBD case,
Uh-huh.
where it's diarrhea and with rectal bleeding. You have suggested, I'm looking at the breathing practices, the hand stretch breathing, ankle stretch breathing, they're all fine, tiger breathing. Now, coming to the loosening aspects, especially the side bending, twisting, and also in asanas, vakrasana and all, because there is so much like ulcerative colitis and all that, right, with this person. So we usually say not to give a whole lot of abdominal stimulation because, they're into this diarrhea. There is very little core, core strength and all. Like basically too much stimulation to the abdominal region is not required. So do you caution them when there is a flare up versus the other times when for these people?
Yeah. So like for him, if you see the loosening practices, side bending, I don't think it'll affect that much.
Yeah, side bending won't affect much,
Unless they're pressing on their belly.
too
So
much.
yeah, when they have discomfort, when they're in acute pain, I think whether it is IBSD or IBD, yeah, I tell them not to do it. Get it a little bit under control, and then start, because the prevention is better than cure. The prevention will come after you get the acute disease under a little bit control, and then you prevent the future attacks.
Yeah.
So,
Yeah. And same thing with the Pavan Muktasana also, right? For GERD
Yes.
patients.
Yes.
You are going, you educate them when to do and when not. I mean, it's a good thing, but it's also, it can get bad.
Yeah, yeah. And yeah, so once they're acute symptoms, we control it. And then we say, like even for this the UC patient, he was having a stressful living situation with this stepdaughter and all that. So that was his perceived stress. For him also, so in ulcerative colitis, the bleeding is mostly, for him especially, it was mostly coming from the rectal area. So usually any kind of relaxing technique will help, which doesn't involve, like you said, too much of pressure on the belly. And initially we also ask them to stop drinking milk, actually, because they develop secondary lactose intolerance. And once the UC gets under control, then we started.
Yeah, there is also Bhujangasana and all that here.
Yeah.
So, yeah, okay, makes sense. All right.
I think the one which he stuck with is, he liked, and I also like this, Vipreet Karani with Brahmari. That was one tested thing for anybody who has problem with sleeping. I have noticed the patients, they love that Vipreet Karani with just doing Brahmari and Vipreet Karani.
Yeah, we sometimes, if they cannot even do Vipreet Karani, we say go take legs up the wall and just
Right. Up the wall only. Most of them are doing legs up the wall, and yeah.
with a little cushion there, so that a little bit, if they can elevate the abdomen, if not, no worries, just legs up. Okay, wonderful, very nice. Yeah, I've seen that you have all pranayama, nadi shuddhi, shitali, shitkari, bhramari, all Om meditation everywhere. That's very impressive. So I also wanted to ask you about, since you are into VA clinic, right? There is also this Yoga Nidra, iRest kind of program, right? Do you like how I didn't see a whole lot of DRT here. I'm sure they are already giving some kind of Yoga Nidra or deep relaxation. Is that part of all the protocols, or how is the relaxation done?
So it's not a part of all the protocols. Some of them, so even the yoga therapist, she ends with a little, not necessarily DRT, but just a quick relaxation, like in she ends with Shavasana with some relaxation. But the Yoga Nidra is a separate program. Okay. And lot of patients in VA have PTSD, and psych unit is using that program the most. So the only thing is that's a separate program. So so I have to refer to it separately. So the problem that comes with that is the patients have to have two different appointments, and sometimes. So right now we are just getting them into the yoga program, the yoga therapy program. And then if they're interested and sleep is the main issue or something, then we send them to a yoga nidra program, because we have a huge population of psych patients in VA. Psych ward is a separate ward, and they have PTSD, suicidal ideation, and now it is all in alcohol intoxication.
Yeah, at least good emphasis on QRT, and making a QRT a little longer, like 3 minutes instead of 3 minutes. If you
They're frozen.
Uh-oh.
Yeah, Ashwini's screen froze, I think. So while she's coming back, Sangeeta ji, I wanted to ask about the PSS scale, right? Did you do it to like one before and one after, or was it done multiple times, the questionnaire?
So we have decided to do it once a month.
Oh, okay, once a month.
Yeah. So it's a questionnaire. They'll fill it out before they start their yoga therapy. The nurse gives it to them.
Okay. Okay, awesome.
Sorry,
also,
my something happened to my internet. So yeah, I just was checking if you can add QRT instead of DRT.
Yeah.
You can. One second. Now, one second. Sorry.
see me? Hear me? For some reason. Can you see me, hear me?
Yes.
Yeah,
Yeah.
so okay, just wanted to check if you can increase the QRT itself, just because there is this whole red tape on what to be given for whom and all that for the insurance sake. If you can make it a little longer, because we see that GI patients are not different from psych patients, like, you already know that. So if you can give a lot more QRT, that might also help them learn diaphragmatic breathing. We say practice diaphragmatic breathing, but unless you lie down and practice, it's very difficult to practice sitting, right?
Correct.
So that's why I was thinking QRT might be a great protocol as a standard protocol for the GI patients. Any other questions from others?
Yeah, I have a similar, I think, question about the protocol with the IBS patient that's the ailment too, because I think I also read that that person has that lumbosacral spondylosis,
Yes.
and also this. So just I did see in the protocol some twists that were there as well, standing, loosening twist, trikonasana.
Mhm.
So just do you advise some caution, or do you tell them not to, or how is that handled?
Yeah. So actually, we have a kind of a question which the yoga therapist has, not a part of this protocol, where she will ask, are you having any acute back pain today? Or are you having this? Are you having that? Before, so she gives them a little talk before she starts, that whenever you have these issues, please let me know beforehand so that I can modify the yoga techniques according to that.
Okay,
So
so she modifies it.
she has a disclaimer or some precautionary kind of a thing which she projects in front of them and tells them that if you have this, don't do this. Like, if, of course, if they have hernia, we are not going to make them do Bhastrika, Kapalbhati and all these things. So she has a list. So these are the list of things I gave her, but then what they choose from that and what she chooses from that, I have mentioned. Like, yeah. So her this thing must have been, the sacroiliitis was not an issue or a problem when she came in. So this patient was a smoker. She had bipolar, PTSD, and so she actually liked these loosening techniques. And the Surya Namaskar also, slowly she did, not like the one, so very step by step in every this thing. And then just sitting up straight and doing this Chakki. She also liked this Chakki Jalana concept. So some of them, they don't like, you tell them a few of them and they will select out, like, this is the one I'm going to stick with because I think I can easily do this. And then the yoga therapist sees that, are they doing it correctly, is that safe for them. So individual, 1 or 2 sessions are individual, and then she puts them in group therapy.
Okay, an individual, they learn obviously their
Yeah.
constraints.
Yeah. And so that they get more comfortable with her and tell her. And then she says, hey, if this happens, you have to tell us. And even before each session, she tells the group that if you have this problem, please don't do this. So she has a way of organizing them into group according to their complaint and her own checklist.
Mhm.
So now, so I have a couple of questions, Mona, if you're done.
I'm done.
So the therapist only receives GI patients, or
She has more of psych patients, and now rheumatology has also started. So there are, so she's the main one, and she has a couple more people working with her, but she decides. I mean, I talk with her directly because I was enrolling her, and I said these are the things which are advised. But for other patients like rheumatology patient and psych patient, she decides on her own.
So in a class setting, she will have everybody.
No, usually the GI patients are in one class.
One class. Okay, that
Yeah.
makes sense.
Yeah, because the trauma patients are a little more, they're different. So she keeps them in a different.
Okay, excellent. I have a question on the scales, right? Like the scale that you have selected, like PSS scale, and for the IBT, you have a different scale. How do you, I mean, how did you select them?
So for GERD patients, so these are some of the standardized scales which are used in GERD research. So suppose I was to do GERD research on the effect of even a medication, a new medication which comes in the market to compare with the standard medication. So the acceptable scale for me to use to have my research published would be this scale. So that's why I use that scale. For a GERD, that's the scale, and for IBS, that's the scale, and for IBD, that's the Mayo scale. So those are standardized by different studies. And once you say that in a research paper, the GI community accepts it and says, okay, this is a standardized scale we are using. So it's a standardized by previous research studies that this is the scale to use.
Nice. And
So-
another question is the medicine score, right? I mean, did you monitor, or was it too early to even say, you know, the medicines, like, because there is list of medicines that they're taking.
Right.
Did anybody reduce anything, or, I mean, I think you mentioned somewhere in one of the case, but
So
did you
in
look into the
3 months,
medicines?
in 3 months, I didn't reduce anything except the GERD patient. After I did the EGD, actually, I doubled the dose. She was already on once a day. I doubled it to twice. And then after 3 months, she was back to down to once. But now she's on a half of the dose, just half an hour before breakfast. And then her ulcerative esophagitis has healed. We repeated the endoscopy. So as a gastroenterologist, I cannot touch other medicines. Only the primary care physician will take care of the other one. But for IBS-C patient, yes, my goal is, so this 3 months is too soon, is to take him off. So once you say high fiber diet, eat regularly, therapy and all that, then we take them off any laxative. So this patient, now it has been 8, 9 months, so he's off of laxatives. Okay, so only on high fiber and all these things he's helpful. So high fiber meaning he's taking psyllium, like fiber supplement also, and drinking a lot of water. So that's the diet part. So drink plenty of water with high thing and eat, and then start walking, because you have to move the GI tract for the constipation. And then all these yoga for relieving the tension and relieving the stress that is causing his IBS-C. Because this patient was like has bipolar disorder, PTSD, and all these other issues also which are affecting.
So I have a question about these medication scores, the same as what Savita asked. Not only medication scores, in general about research, right? Do you have, are you planning to document these and submit somewhere at one point? Is one question. And the second question I have is regarding the medication score. Although you are not going to be reducing other medications, we see that there are lots of different medications, hypertension related, and Ativan for, you know, the sleeping, you know, related stuff, and all the anxiety and stuff like that. Do you keep track of this other medications and also document them? Just because you are giving this yoga and other holistic therapy for them.
Yeah, every time he comes to he or she comes to a clinic, we document the medication they're on. So the documentation is there. If we collect the data, we'll know whether they came out of it. Ultimately, it would be good to have a study in which I involve the primary care physician and say, listen, if we do it so that we are working on everything. Like if this patient has bipolar disorder and PTSD and all that, the major problem is not IBS-C at all. So if we can collaborate, do a collaborative study which we are focusing on everything, that would be ideal situation. So for that, I have to bring other physicians on the same page. And sometimes it's not that they are not on the same page. They understand what I'm saying. It's they don't have the time to.
No, it's not just that. We have seen that when people start yoga and modifying their diet and lifestyle and stress, many of the other medications have to be reduced. It's not a question of whether they are reduced or not. So if they are not reduced, they are getting over medicated anyway. So in especially in Prashanti S. Vyasa Health Center, right? So because they are already watching and there are doctors on board and everything, they monitor their glucose levels, for example, or their blood pressure. So giving them more medication can actually be harmful.
No, I agree with you. And
that's why I'm
as
asking.
I said, we are documenting, so we can always go back and check a document and see if they reduce the other medication. The other difference, Ashwini ji, is in places like Prashanti and all that, there is an atmosphere also. Like it's like these people, they're here and then they're at their home, which where all this is happening, or whatever the stress is happening, and then they come here once. So it'll take them this is like it'll take them few years of complete dedicated yoga practice and belief in it, because some people give up, they like give up halfway because oh, it's too much to they don't realize that it's helping them or whatever, or they think it's too much to fit into my schedule. Like, really, this is the most important thing to fit into your schedule. Everything else will fall in place. But sometimes it's hard. So, but if you're coming to a place like Prashanti, that means you're already dedicated. You are already committed. Your mindset. Okay, you're living in an atmosphere where you're seeing everybody else practicing the same thing. So there is a huge difference in the effect you will see in that kind of scenario. Like if you go for a yoga retreat or a meditation camp, and then you come back to real life, the effects are not the same.
Yeah, we understand that. So, however, that's why I said few months, right? And also, of course, not everybody. The point I was trying to understand is as they follow certain, not even necessarily yoga, right? You are already suggesting lifestyle changes and a lot of little things like diaphragmatic breathing and some of the coaching that you give in general. Would they also would help? So if other physicians of other specialists also get involved, and if there is some collaborative effort, that will probably be much more effective, is what I was thinking. And whether we are doing even justice to by like, for example, are you allowed to suggest that they have to go and talk to their, say, psychologist or psychiatrist, see, go check if you're sleeping well, why do you want to take these medications? Are you allowed to say that?
Yeah, we talk to them. We actually talk to the psychiatrists ourselves. We'll call them and discuss that. That is not the problem. And actually, it will be. We have a huge diabetes clinic, and it'll be interesting to see. And we have a huge group of NAFLD patient, non-alcoholic fatty liver disease, which is like the #1 growing liver problem in US right now. And those we are seeing improvement. In those patients, we are seeing improvement because we can do fiber scan now, which is under control to see the AST, ALT are improving as their BMI improves. So we are trying to see if we can get the diabetes clinic. The other problem in our thing is we're short staffed, and the diabetes clinic is run by just 2 physicians. And if I tell them, like, they will do what I want them, if I advise them to do, but they will not spend that extra time in convincing the patient. So they say, hey, we also have yoga therapy available if you're interested. If you're going to offer them like this, they're like, oh, yoga, okay, well, I'll think about it. So you have to be engaged or believe in it for your patient to believe in it.
Agree.
That's a good segue. I have a question about, because I'm seeing just the the client compliance to yoga therapy protocol? It sounds like these are weekly sessions that they're doing from the yoga therapist. Is it once a week that they generally
Yeah,
come?
yoga therapy was done once a week by the therapist, but some of the things which were taught to her, she was started doing it every day, like the diaphragmatic breathing. Some things she was doing regularly at home, and she would tell me when she would miss, like when she had a travel thing, and everything became. I mentioned that, and then she came back online. So she would tell me if things got messed up with her schedule, and then she would go back on track. So some things we told her to do every day, and the yoga therapy was just once a week.
So how do you give them the home practices and suggestions for how long and how many days? Is there something like a sheet or something, or is it just training one-on-one and they go home and do?
No, so the yoga therapist writes, she gives them a sheet of paper to practice, and she would say, like, you practice once at home, and if you can do these three things every day and record them, and then they have to make a check mark on if they have done it or not. And we tell them it's not like you're going to pass or fail if you don't. Just be honest so that we can actually know the effect of it, whether it's working or not. So, and the first patient was completely. It took me a while to convince her, but she was completely in sync with the program.
That's impressive because even with what we do, we sometimes even advise twice a week to start with.
Right.
Right, individual sessions, even, start with twice a week. Sometimes they even come 3 days a week. And so to take participant and say once a week come and then go home and practice. I mean, it's impressive you have that compliance that people do.
Right. It's every patient is not that compliant. I mean, and the reason we tell them to do daily is even if they end up doing 3 times a week is good. If we tell them to do 3 times a week, they will probably end up doing once a week.
Yeah.
So it's better to say, hey, this is what you do every day. Take half an hour for yourself every day. That's it.
Yeah.
And do this. And if you put a time to it, this will just take 20 minutes every day. So then they think, okay, I can spend 20 minutes on myself.
But definitely what we see are the participants who maintain their home practices are the ones who definitely charge the best.
Sangeeta, I missed you when you mentioned about how they are paying right now. Are they paying through by like just self-pay?
No, so in veteran hospital, the medical care is free for the patients because they were veterans, war veterans. So,
Right. Yeah. Makes
so
sense.
that's a good thing.
Right. Yeah.
Yeah, that's great.
Sometimes they take it for granted, but it's still a good.
Yeah. One last thing, actually, we had approached our VA hospital in Oklahoma, or they approached, we had some conversations, and they mentioned something about recreation. I mean, they have some yoga, which is not so comprehensive at this point. They have recreation yoga. So they were like, as we sent what we do, and they were very excited. It's just the distances are so far right now, and we tried to bring some. It's not too, we haven't got too much into them, but it will be nice to give an example of what you are doing in your setting to these people, so that across states it might help influence.
So this place in Oklahoma, is it a private hospital or?
No, this is VA hospital, right?
Oh, VA hospital.
VA hospital, yeah. Oklahoma City VA hospital.
Okay.
Dr. Birju Shah.
VA hospital, yeah. VA hospitals, if they get into it, they can make a very nice program. I mean, because they have the money and the funding to do it.
Right.
Okay. All right. Wonderful. Thank you very much. This is we had set 1 hour. I don't want to take more of your time. We are just deeply impressed with what you have done, and you have also completed our entire yoga therapy program for doctors, and congratulations and thank you for even participating in this whole program. We learned a lot. You know, we are ready to move ahead with the certification program. Yeah. Thank
And
you.
please let me know if I can get involved in some way in
Oh,
any
wait. Let me stop the recording here. Yes.